Welcome to the Egg Whisperer Show. I'm Dr. Amy, and today we're celebrating clarity, empowerment, and the science of truly understanding your body. We're also doing a little myth busting and talking about the fertility patient mindset. This week's episode is called The Lucky Egg, Understanding Your Fertility and How to Get Pregnant Now. And I'm so delighted to welcome back my colleague, Dr. Lucky Sekhon, whose new book just came out on January 13th. If you've ever wanted grounded, uplifting guidance that helps you make sense of your next steps, this episode is for you. Dr. Lucky is a double board certified reproductive endocrinologist, infertility expert, and the author of The Lucky Egg. Today, we'll talk about common fertility myths and what people really need to know as they move forward. Welcome, Lucky. Thank you so much for joining me today.
Thank you. This is a real full circle moment. I've been on your show several times, and I feel like you always were so kind and generous with your platform. Thank you for having me back.
Oh, thank you, Lucky, for joining us. And like you said, you've been on the show before, and it's so awesome to have you back. And your new book is officially out now. Catch us up on how it came to be. What led you to write The Lucky Egg and bring it into the world?
It's actually a crazy, magical story. The natural progression was that I had been at least 6 years into practice and had at that point seen thousands of patients in all different scenarios. And the common thread that just kept coming back up over and over was how little information people tend to have about how their bodies work and what it takes to get pregnant until they run into difficulty. And just seeing how it makes it so much harder to navigate decision making and how to move forward with confidence when you don't know the basics. And so I've spent so much of my career trying to bring people up to speed. And that's where social media came in, because it felt like something that was easy, that I could tackle it in small increments of time, like 20 minutes here, 20 minutes there to make a video. And short form videos just felt like something I could do as a full-time clinician and as a mom of 2 kids. And I sort of grew frustrated with it a little bit. I mean, don't get me wrong, I'm going to continue to make content, but I felt like it was still too fragmented and there wasn't really like a way to lay the foundation and bring everyone up to speed the way I wanted to. In early 2023, started to think maybe I will write a book one day. Like it would be so nice to put everything together in a cohesive way and have an index. But it felt so overwhelming that it was on the back burner, right? And I don't know why, but I happened to mention it to a patient of mine. And she didn't say anything about it. And she froze her eggs with me and we remained in touch. And one day she called me back up and said, "Hey, do you still want to write a book?" And I had completely forgotten I had even made the offhand remark. And she said, a really good friend of mine who works where I work, but she's a book agent specifically, she is going through her own infertility journey and she cannot find a good resource. Like she can't find what she needs. And she said she's been relying on your Instagram for a lot of information. She's been going online. And a lot of our patients do that, right? But this happened to be a book agent who was also scouring, all the books and not finding what she needed. So she asked her, "Oh, I saw you follow her on Instagram. Would you be able to connect me? Do you think she'd want to write a book?" And she goes, "I actually know that she would because she said it to me." The rest is history.
Yeah.
We got together. We had an amazing brainstorm session. We were very aligned with what needed to be done. And we made the decision at the end of a 2-hour meeting, our first meeting, that we were going to do this together. And she was going to walk me through how to write a proposal. Like I started with 0, right? And then like a week later, her transfer failed. And she said, "Is it weird if I become your patient?" Because she wasn't my patient or at my clinic. And then you're writing this book. Yeah. So I was like, let's just do this. And she ended up finding out she was pregnant the week I got my book deal. And then I handed in my manuscript the weekend she had her baby. I just felt like we were on this like parallel path, but for different things. And we both helped each other. And it was just like such a beautiful thing that unfolded in my life. And I'm so happy.
I love that story. And I love what you post. It's just so nice to see that so many people are seeing what you're sharing and it's making such a difference. So many people look for guidance while preparing for pregnancy long before they even see a fertility specialist. In your experience, what should people focus on during that phase?
So I think that education should be a huge part of it, right? I think that a lot of people don't realize what it takes to get pregnant, and that can inadvertently end up wasting time. So I think, really focusing on your cycle and understanding what is the pattern? Is there a pattern or is there no pattern? And if that's the case, maybe you should go directly to see a doctor and don't wait. The guidance of wait a year or wait 6 months and then see a fertility specialist doesn't apply if you don't have a regular cycle. And it can take around 3 cycles at a minimum to really start to see an established pattern. And you can use a variety of methods, but whether you're using the calendar method or you start using ovulation predictor kits, putting that data together, it can take time. So I think that's really the first thing. Obviously, you want to be on a good prenatal vitamin that contains folic acid. And ideally, you should be on that 3 months preconception. And I always say keep it simple and think about it as whatever's better for heart health tends to be better for not only fertility, but pregnancy health as well. And so when you're thinking diet, you're thinking Mediterranean style diet, again, better for heart health, better for your fertility, regular exercise, trying to fight the very natural tendency in today's world to be sedentary because we spend so much time sitting at our desks for a lot of us. And thinking about what are the things in your life that you could cut out that are not serving you, like smoking or vaping, and cutting alcohol down to a very minimal level where it's like less than 4 drinks in a given week. And I think also preconception testing is something we need to be talking about more. There isn't necessarily a guideline that says this, but we know as doctors that treat women in what we call trimester 0 or when they're trying to conceive, we will offer preconception testing for things that are traditionally only found out about once you're already pregnant, like genetic screening, right? So seeing what you and your partner carry, if you carry any mutations. Now panels cover anywhere from 400 to 1,000 conditions. And it can be really empowering to know going into pregnancy attempts that you and your partner don't overlap, or maybe you're a carrier of something that could affect 50% of your future sons, or you both collectively have a 1 in 4 chance of having a child with a certain condition. It doesn't necessarily mean you're going to do something proactive, but I think it allows you to make an informed decision and go into that pregnancy attempt prepared. And if you do want to be proactive, it opens up the conversation of, do you want to maybe avoid being in that situation altogether? Do you want to do IVF and make embryos and test them for a specific condition? In a similar vein, trying to prevent problems before they start, I always check things like, are you immune to chickenpox, the varicella virus, or German measles, rubella? These are conditions that most people have been vaccinated for, or maybe they were immune at one point, but their immune system can forget the immunity. And those are viruses that can lead to complications if you contract them when you're pregnant. So I always try to avoid problems before they start. And that's what I really think about when I think about preconception screening or things that people could be looking into or doing. I'd love to hear your take on this because it's kind of controversial because it's not in a guideline, but I'm a big believer. I think not everyone across the board has ever had a pelvic ultrasound at least once in their 20s or 30s. A lot of times I'm seeing patients sometimes in their late 30s, and I'm the first one who's ever done a scan on them. And I think it's not really a guideline because how many people would you need to scan to find something? But I do think that there can be a lot of different conditions like fibroids, depending on their location. There are women that were born with something called a septum. I think there could be things that you can pick up early that people would appreciate having that information before they're already pregnant, especially because some of these conditions can predispose to miscarriage. So I think, going to your GYN or even your primary care doctor and saying, hey, I'm thinking about getting pregnant. What should I be focusing on? And also reviewing the list of medications that you're taking because you want to make sure what you're on is pregnancy safe. So just really thinking ahead about, what can I do to optimize my health?
Yeah, I couldn't agree more. It's like a no regret plan pre-pregnancy so that when you're pregnant, you don't wish you had known something first. And when, let's say you're planning a cross-country trip in your car, you're going to go get your car checked, right? But like, it's the same thing. Pregnancy is like a cross-country trip and it's so involved. Like, what's the big deal if you get a pelvic ultrasound? I couldn't agree with you more. And then what about some of the things that people worry about or try to control that aren't actually helpful? Like, what are some of those things that you see in your practice?
I think people tend to be needlessly restrictive with their diets, and it's a lot of misinformation that they come across on social media. They may cut out entire food groups or entire categories of foods. I've seen a lot of people cut out dairy, for no reason. Of course, if there's an intolerance or a reason that you need to not eat something, that's a different story. But I think that there's a lot of baseless advice that people come across on social media. And then, they're overly restricting themselves and they're focusing on things that burn them out, but don't necessarily make a difference in the long run to whether they're going to get pregnant easily or not. And so I think this mentality of life in a bubble, that's what I call it in the book, is really what I'm trying to avoid. Of course, we know there are lifestyle habits or exposures that are less favorable, right? And we talked about some of them. But I think that people really beat themselves up. And there's this
Right.
tendency to blame themselves for everything that they didn't eat or the supplements that they didn't take or, the things that they did do. I've had patients cry in my office about the fact that they feel like they drank heavily when they were in college 20 years prior, and that now that's why they're dealing with infertility. So I think that we have to focus on the here and now and how we move forward. That's the first thing I'll say. You can't change the past. And just because you did something that was deemed unhealthy or maybe could have a negative influence on fertility in the past doesn't mean that that's actively impacting your current fertility.
Right. And the things people see on social media, they internalize it. So there's so many myths out there, and you cover a lot of them in your book. Let's do some myth busting right now. What do you say?
Let's do it.
Okay. So the first one, a low egg count means you're infertile. Tell us about that myth.
So, in order to understand this and why it's a myth, it comes down to the education about simple things that are happening in our body, right? When we're ovulating each cycle, you are only releasing one egg. There are a bunch of other eggs that are available at the surface of the ovaries, and those are visible as those bubbles of fluid. They look like black circles on an ultrasound. Those are called follicles. And even that pool of eggs that you can count on an ultrasound, the follicles, don't represent all the eggs that you have, right? It's a representation of a very limited subset of the total number of eggs in your stockpile. You are born with a certain stockpile of eggs, and imagine they're like two pantries buried deep inside the ovary. And every cycle, you have waves of recruitment from the pantry in a way that we cannot influence. I don't have the keys, it's locked, and neither do you, right? And basically, the number that comes to the surface, I use the term pantry because it's almost like rationing. The more stockpiled your pantry is at a certain snapshot in time, the more you tend to bring out of the pantry and kind of put into the see-through kitchen cabinets. Those are the ovaries that you can count and actually look at what the follicle numbers are on both sides on the ultrasound. And then your brain sends a signal, and only one of them randomly gets selected, like a lottery, to be the one that gets to ovulate. So whether you have a high egg count, a high number in your stockpile, and therefore a lot get rationed to the surface each month, or a low number is not going to influence the odds of that one egg that you're ovulating actually turning into a baby. You're on a level playing field with everyone else. The thing that makes it different between one individual and another, there's a lot of different factors, right? Because there's a lot of things that have to happen between ovulation and actually becoming pregnant. But when we think about the influence of egg quality, what we're really talking about is what are the odds that when you have that random lottery where one of those eggs gets selected at random to ovulate, what are the odds that that egg can turn into a healthy embryo? And that's never perfect for anyone. And it is something that diminishes as we get older. But even in our 40s, you still have some healthy eggs and you can randomly ovulate a healthy egg. And that's actually the driving reason behind the name of my book. Of course, it's a play on my name, but it's really to give people hope and illustrate that there's a lot of randomness in this. And you're not out of the game just because you turn 35. Your fertility is not a cliff, it's a continuum.
It doesn't happen that fast. That's so true. How about this next one? Miscarriages are preventable with enough progesterone or bedrest.
Miscarriages are very much not preventable in the vast majority of cases. And that's not to make you feel completely out of control or, out of hope because you can't do anything to modify, but it's to absolve you of the guilt, right? If you're listening to this and you're someone who's had a miscarriage, it is a very normal knee-jerk reaction. It's human nature for us to think, what did we do? Was it stress? Should I have rested more? Should I have taken more vitamins? What did I do wrong? And I'm here to tell you that the vast majority of first trimester miscarriages are because of ovulating an egg that had something missing or extra in terms of the amount of DNA. That's like 90% of the causes in the first trimester, right? And that egg could get fertilized and it could get to the stage of being an embryo and get to the uterus and it was able to implant. But then the missing or extra DNA that was there caused dysfunction in its growth and development, and it stopped growing. It's not because your body knew. A lot of people assume that. They'll say, oh, well, my body knew that this was not a good embryo and then it kind of stopped it. No, your body doesn't know. Your body's kind of passive in this process. And think about the lining of your uterus, like the soil, and the embryo is like the seed. And if the seed stops growing, it's because it's lacking something or it has too much of what it's, not supposed to have. And there's nothing that you could have done to change that, right? In the vast majority of cases. Other common causes are something maybe structural in the uterus, like a fibroid that's in the inner lining that interrupted the embryo from being able to properly implant and expand. But again, not your fault, right? And I think a lot of people get caught up on progesterone because what progesterone is basically when an embryo is implanting, it starts secreting a signal. That's the pregnancy hormone that you see, the two lines when you pee on a stick or when you do your blood work, your beta HCG. That beta HCG that's being secreted by an implanting embryo is sending signals to the ovary and telling the ovary, hey, I know you just ovulated, and let's have you keep making more progesterone because I'm here now and I need the progesterone. You need to keep stabilizing the lining and make it a nice environment for me. And eventually, once my placenta grows, then I'm going to start making my own progesterone and you can go away, right? When people have an early pregnancy that's not functioning normally, and oftentimes it's the genetics or other problems that you could not have controlled, that signaling is not doing what it's supposed to be doing because that embryo is struggling. And therefore, you might see lower progesterone levels. And so it's always like, what came first, the chicken or the egg, pun intended, because people are always thinking, well, if I take progesterone, I'm going to be able to rescue that. But I think a lot of times the low progesterone is a symptom, not a cause of the miscarriage. And obviously, this is talking about if you ovulate and get pregnant. In the case of IVF pregnancies, you're not necessarily ovulating. And so we're supplementing you with the progesterone. And that's why it's important to always make sure you're taking it as your doctor directs you to and not stopping it prematurely. Even if you have a negative test at home, you really want to make sure because that pregnancy is relying on the progesterone that you're supplementing if you're not making it on your own.
When I diagnose a miscarriage, and sadly it is a part of our practice, I always tell patients the first thing that you're going to do is you're going to ask yourself, what did I do to cause this?
Yeah.
And patients will say things like, oh, is it because I bent over and picked something up? And we constantly have to remind people that it's not your fault. You didn't cause this. So I totally agree with you. So here's our next one. IVF is a guarantee and egg freezing is your insurance policy. How do you debunk that myth?
I don't think we can ever talk in absolutes. I think anytime you hear something that sounds that extreme, you should always question it, right? And it's always a little bit more nuanced than that. So IVF is sadly not a guarantee. We've gotten really good at it, and it can work really well to the point where if you have a really high quality embryo that looks good, we grade it according to how it looks under the microscope. And we can also genetically test them. And so if we know it's a healthy embryo in all the ways that it can be, at best, we can say maybe there's a 60 to 70% chance of live birth. That's as good as it can get. The 1/3 that don't implant, that don't result in a live birth, it's probably, sometimes still the embryo because PGT can only zoom in so far. We're only looking at a small number of the cells that actually make up the entire embryo. So there are limitations. And it's not just about having the right amount of DNA. We have the right amount of chromosomes, right? But our bodies can break down in other ways. So it's really one of those things where people can start to feel like a PGT normal embryo is a guarantee. But I always level set and remind people, even going into the transfer, I feel really good about this. Your uterine lining looks great. We've looked at everything. We've controlled everything we can. Now it's kind of up to the universe. But at best, it's a 2/3 chance. And it might take more than one transfer to get there. Now, there's a big study that was done in recent years that gave a really, really nice statistic that with 3 embryo transfers, with 1 embryo being transferred at a time, so your cumulative, if the first one doesn't work, then you do a second, and then that doesn't work, you do a third. Usually that lends itself to about a 92% cumulative live birth rate. Now, for the people that have had 3 or more failed transfers, I know that sounds so scary. Why am I in that outlier category? But there might be other things going on, right? It might have to do with your uterine lining. A lot of my patients who have experienced 3 or more failed transfers, there might be something going on in terms of they've had scarring in the uterus, and we're working on that and trying to get that to a better place. Sometimes, though, you're not going to have a clear reason. But those cases are few and far between, but they are really important to focus on because we don't know everything that there is to know. And so I think that's where people really find this whole process stressful, because I think a lot of times they go into IVF thinking, I moved from IUI to IVF thinking this was the solve for my problem. And now this is kind of unexpectedly difficult. And it can be difficult for two reasons. Either it's hard to make the healthy embryos, or it can be hard to get those embryos to stick, or some people will have challenges in both of those arenas. So it's not a guarantee, but you have every reason to not be afraid and to feel optimistic. But it's important to realize it's not 100% success rate per transfer. And then let's talk about egg freezing. Egg freezing is not a magic fix for the inefficiency of human reproduction. So if you tell, 20-year-old that there's a 20 to 25% chance that the one egg they randomly ovulate that's chosen like a lottery will fertilize, grow into an embryo and implant, that inefficiency doesn't magically go away just because you did egg freezing, even though it feels high tech and it feels like this whole process. You're still working within the confines of that inefficient system. So that's why we always kind of try to emphasize this point when we talk to patients and say things like, it's like a 10-to-1 ratio of how many eggs does it take to get to a live birth. But the nice thing about IVF or using eggs that were already retrieved and frozen is that instead of working with only one long shot, if you have a good number, or you got a good number over several cycles, if you're battling diminished ovarian reserve, at least you're working with multiple long shots. And then you can kind of watch survival of the fittest when you go to thaw them out and turn them into embryos. But that's why it's really important to talk to your doctor about their experience with thawing the eggs. What do they typically see in their lab? And for your age, how many is a reasonable number of eggs to try to get to your family building goal if you need to rely on these eggs, which you might not need to rely on them.
A lot of patients don't have those conversations. They just do one batch of egg freezing, they forget about it, and they come back at 43. They froze their eggs at 36 and learn the hard way that they should have frozen more. And then same thing, I see patients where they, did 3 IVF cycles, they have 1 PGT normal embryo, and they're surprised that it didn't work because no one had these conversations with them. So I'm glad we're having them here today for people to learn from.
Same here.
Okay. Next myth. The longer eggs or embryos are frozen, the worse the outcomes.
Yeah, I always get asked this question, and it makes sense why people would assume that. You're kind of thinking, hey, freezing, you're thinking about, the chicken breast you've had in the back of the freezer for the last decade and how it probably has freezer burn. But thankfully, it doesn't work like that when we're actually keeping eggs and embryos at a very cold temperature, minus 196 degrees Celsius, in liquid nitrogen. It's halting all aging and metabolism. And there's actually really miraculous stories of people using donated eggs that have been frozen for over 20 years that have resulted in live births. And that's pretty cool too, because, with that time frame, our freezing technology got a lot better. Now, I would say since 2010, most centers have been using consistently vitrification, which is rapid freezing, versus slow freezing, which was the older initial technology. And now we can say, okay, there could be like a 90% thaw survival rate of eggs, which is really remarkable because eggs are just a single cell, right? And that thaw survival rate and the ability of that egg to turn into an embryo and eventually a baby is not affected by how long it was frozen, and same for embryos. And your uterus also doesn't really age in a major way. So that's also a really uplifting fact that I like to include that as part of the discussion on the biological clock, because that is why freezing eggs and embryos can be really helpful. I've had patients who froze embryos at 39 as part of their initial IVF treatment with me, and they've come back for baby number 2, baby number 3, all the way up to like 45, even older than 45. Maybe they were even entering perimenopause, menopause, and they're still able to get pregnant with the same level of success.
Okay, so the next myth is sperm do not have a biological clock. Bust that myth for us.
This is a common one. This is still surprising in 2026 to many people, because I've been having a lot of conversations, bringing my book to the world, and male factor fertility and male age have come up a lot. And I think we're only now coming around as a society to the idea that men and women should be tested concurrently because fertility is 50-50. That should be common sense, but it's taken a while to get that knowledge out there. And I think the biological clock, a lot of people aren't aware because they know it is a true fact that men are always making new sperm. New sperm cells are generated on a 74-day life cycle. And yes, men can make sperm in their 60s or 70s, even their 80s, and they can father children. But it is important to realize that men are not immune to the biological clock. It just ticks differently. For women, we have a limited number of eggs. We don't have repair mechanisms. So the ability to get pregnant and stay pregnant tends to be very linked to age when we think about egg quality, right? For men, it's not about getting someone pregnant, but it's more about the quality of the pregnancy. And you can accumulate mutations over time as a man that are passed through the sperm DNA to a future child. And so there are many association studies that have found associations between advanced paternal age, which, by the way, the literature hasn't come up with an agreed definition, but a lot of studies say over 45 for men, some say over 50. But definitely at the extremes of age, there can be associations with neurodevelopmental issues in children. Autism has been linked to advanced paternal age. There's even some papers that have shown a potential link to things like childhood cancer. And so it does make me think, as a fertility specialist, if a man knows it's likely not in the cards that he's going to want to have kids anytime soon and he's in his 40s, sperm freezing is so much less invasive and easy and cheap compared to egg freezing, but you hardly hear of anyone doing that. And maybe it's because no one really in their 40s sets out to say, I'm going to have children in my 70s, right? As a man. But
Right.
I don't know. I just feel like it would be a contingency plan, knowing what I know that I would make use of as a male, if I was like kind of entering my 40s or 50s and hadn't had children yet.
Yeah, I couldn't agree more. When I have a discussion with someone and the sperm provider is in their 50s, I always give them this talk first because I would hate for them to have a baby that's autistic and then say what caused this and have that time be the first time that they had that discussion. I don't think
Yeah.
that's fair. And I've had couples choose a young sperm donor through a sperm bank because of the information that I've shared with them. So, what do you wish patients knew about first on their quest to the lucky egg? And what do you think is missing in today's world of fertility care?
Not to sound like a broken record, but I think it's the basic education and knowledge. I think that once we fill the fertility knowledge gap for everyone, regardless of whether they're trying now or planning to try in the near future, if everyone would read this book or just get themselves educated as they enter their 20s, I think it would lead to a better landscape across the board. I think it would allow people to have more realistic expectations of how long it may take to get pregnant. And that might have subtle impacts on the things that they do in their personal lives, even subconsciously. And I know this from my own experience because I used to, as a medical student, say to myself, oh, it's going to be such a long road for training and all of that. I can't see myself wanting to even think about kids until my 40s. And I'm not saying that there's a wrong way or a right way, but I found myself personally in a situation where I was with my long-term partner, my husband, earlier than that age. And, even when we got married, we weren't set up in the right living situation in New York City to have kids because I had already kind of primed him mentally. I had said to him when we were residents, I said, listen, like, I'll finish my fellowship training and then we're going to have many years to travel. And I kind of like set the tone of we're going to start trying in our late 30s, early 40s. Like, don't even put it in your mind. And we'll freeze some embryos because, of course, I'm a fertility doctor and I know that that would be a good idea. And then as I got into my fellowship training, I was like, oh my gosh, like I kind of had this illusion of control. And now that I'm actually in practice seeing all these things play out, it kind of just in a very subtle way, or maybe not so subtle way, influenced my decisions. And one day I just came home in my early to mid 30s and said, actually, I think we should change our plan and I think I should get off the pill. And he was just like, what? But it kind of changed my mind to actually see the reality of things play out and to know that while you can have access to all the things and the technology, you can't control everything. And it wasn't a decision made out of fear, but in that moment, it was kind of like I sprung into action because of all the things that I was seeing. It was like an epiphany. It was more of an epiphany than me being freaked out. And I think my husband was freaked out. But I think that, if everyone in their 20s learned more about their biological clock, they would be able to make a better informed decision about egg freezing at an earlier age than when a lot of people will typically present to talk about it. And then in turn, the success rates will go up because you'll typically have more eggs retrieved in one cycle and they'll be, able to have a higher conversion rate into healthy embryos. And I'm not saying everyone has to freeze their eggs, but my hope in writing this book and all of the resources that are coming out and the conversation and dialogue opening up about fertility, my hope for the future is that the case of someone saying in their late 30s or their 40s, now I'm ready and I'm going to freeze, but it can be difficult if they have really bad DOR,
Mhm.
and them feeling like it's just not an option for them and they never got the option. And if they had known the information earlier, maybe they would have done something differently. I just don't want people to have regrets. I don't think everyone has to freeze their eggs, but I
Right.
think everyone should think about what they want out of life, their personal goals, and have a clear understanding, being able to overlay that with like the biological facts and to make smart and informed decisions for themselves. And if the decision is they decide not to have children or they decide they don't want to freeze their eggs, then fine. But at least they did that decision making. They made that thoughtful decision based on accurate information.
Right. I feel like my patients who, they were given the information, they chose not to do it, they're not going to be angry in the future because they were given that information. The patients that feel like, why didn't someone tell me? Like, they're the ones that carry the regret and they feel like they miss an opportunity. So
Absolutely.
I totally agree with you. So for listeners who want to learn more, get a copy of your book, or follow along with your work, where can they find you?
I'm on Instagram at lucky.sekhon, Sekhon. I have a website by the same name, theluckyegg.com. And then my book is available everywhere internationally. And I think it's a really great guide, not only for the people that are in the trenches of infertility with maybe more complex cases, but it's really the book that helps someone understand what is the biological clock and what do I really need to know and what does my cycle mean and what are the things I need to be thinking about as I prepare for the future and everything in between.
I agree. Lucky, thank you for coming back and for sharing your wisdom. Your book offers such clear, compassionate guidance, and I'm so thrilled people can learn from you in this new way. All the links to what we covered today will be in the show notes. Be sure to subscribe to the Egg Whisperer Show on YouTube and Spotify. And remember to keep going with hope in your heart and a little sparkle in your step as you move forward on your fertility journey.